Hello, assalamu alaikum, my dear student. How are you all? Sorry for late, and there are some technical problem. So today we are to discuss about board question. Today I will discuss briefly about board question on anemia. Anemia is always really interesting topics and disease. You can be asked uh, anywhere in your examination system. You can find it in your board examination, in your data presentation. Even you can you have lots of questions you have to face in your long case, in short case, and in you will find datas on OSP examination, and even in the written examination various questions are being given. So anemia, definition of anemia, I think you know all about uh, anemia. Clinical symptoms, first thing you should remember something that examiner can ask you from disease, or he can ask some snapshots from different system. So and he will judge you how you can evaluate a patient, how you can deal a patient when you will face a patient, and on the basis of maintaining sequence, history taking, physical examination, investigation, and a bit of management. So it is good idea for us to go through a disease from very beginning to the last, so it will be very easy for you. When by examination will ask from any point, you will be able to answer. Symptoms, signs, pallor, koilonychia, jaundice, tachycardia. So a examiner can make a clinical scenario regarding pallor or koilonychia, and he or she will ask you the what are the differential diagnosis. So if we know the sign and symptoms of anemia and patient clinical scenario, you will be able to have an answer. Clinical manifestation of anemia: dyspnea on exertion and palpitation, angina, angina pectoris in case of older patient, intermittent claudication, murmurs, systolic flow murmur, cardiac failure, wide pulse pressure, collapsing pulse, high cardiac output state, and JBP. Think that examiner may ask you that you find a patient having murmurs, but he or she had no previous congenital heart disease or previous heart disease. It is a newly developed murmur. How to approach? So approach system is after performing all the cardiology examination, when it will be normal. So we have to think that if patient had severe murmur, a functional murmur may develop. So we should keep in your mind that murmur can develop in case of severe anemia. More clinical manifestation of anemia: faintness, giddiness, headache, tinnitus, spots in the eyes, lack of concentration, drowsiness, numbness, tingling of hands and feet. Continue clinical manifestation: abnormalities in the fundi are essentially associated to severe anemia. Okay, if you know this important part, nowadays it is not important for us now. And the reproductive system: what signs and symptoms may a female patient come to you regarding anemia? It is amenorrhea and menorrhagia. Nervous system: proteinuria, gastrointestinal system. Anorexia is the most commonest symptoms. Flatulence, nausea, and constipation may present. Mild pyrexia may occur in severe anemia with a hyperplastic bone marrow. And classification of anemia, as we know, morphological classification on the basis of MCB, MCH, MCHE. In my previous class, we have discussed a lot regarding the anemia classification. Microcytic hypochromic anemia, normocytic normochromic anemia, and macrocytic anemia. We know the cause of all of this. Microcytic hypochromic, it is more important. Main cause is iron deficiency anemia, and in our Bangladesh, you will find thousands of patients when that you will go to in your medicine ward. Normocytic normochromic anemia, acute blood loss. If you keep in mind this acute blood loss of hemolysis. Macrocytic anemia, as we all know, B12 folate deficiency, and there are some other causes. And after, if we perform blood film, what will be the finding? In case of microcytic hypoanemia, microcytes and other morphological types, normal sized blood cells, macrocytes, anisocytosis, shape variation from normal round. So, only a question is asked: what are the blood film finding in case of iron deficiency anemia? We have to know this. Reticulocyte count. What are the causes of reticulocyte count? Peripheral smears. It is target cell. Yes, if you look for these slides, very interesting. Basophilic stippling. Look here. In case of bar cell, ovalocytes, look, Howell jelly body. We can find it post-splenectomy, and even celiac disease, Howell jelly body may be found. Schistocyte is very important slide. Frequently asked, what are the causes of schistocytes? We should have to know, keeping in mind that this question is asked in various part of your examination system. Causes of fragmented RBC. Schistocyte means fragmented RBC causes DIC, thrombotic thrombocytopenia purpura, hemolytic uremic syndrome. If you know all of these three causes, very much important for all of us: DIC, thrombotic thrombocytopenic purpura, and hemolytic uremic syndrome. In case, if we find a case, we have to perform blood film, and we'll, at that time we will find schistocytes. Sickle cell is found in sickle cell anemia. Look on it, spherocytes, stomatocyte non-internal target cell, teardrop cell. We can find it in myelofibrosis. Basic pathophysiology, categories of anemia: blood loss or hemorrhage, impaired red cell production, inadequate supply of nutrients essential for erythropoiesis such as iron deficiency, vitamin B12 deficiency, folic acid deficiency, and protein caloric malnutrition. Basic pathophysiological category of anemia: depression of erythropoietic activity, anemia associated with chronic disorder, infection, connective tissue disorder, inflammatory disorder, disseminated malignancy, anemia associated with renal failure, aplastic anemia. Anemia due to replacement of normal bone marrow, leukemia, lymphoma, myeloproliferative disorders, myeloma, myelodysplastic disorder. Basic pathophysiological categories of anemia continue: anemia due to inherited disorders such as thalassemia, excessive red cell destruction due to intrinsic defect in red cells, due to extensive defect in red cells. Key points. So, what are the key points when that you will evaluation a patient of anemia, and the examiner will ask in your even in a long case, even on your board examination, or when he will give a data to you, asking that what are the history point, and that you will take of a anemic patient. Full medical history with special emphasis on the following points like age, sex, rate of onset, rapid, slow, blood loss. In case of female, they're more vulnerable to causing iron deficiency anemia. And alimentary system, we have to perform full alimentary system examination, and history points are appetite, if there are weight loss. If there are weight loss, we have to think that there are some chronic diseases are going on: regurgitation, dyspepsia, abdominal pain, diarrhea, constipation, jaundice, soreness of tongue, previous abdominal operation, reproductive system, menstrual history, number and interval of pregnancies, miscarriages, central nervous system, paresthesia, difficulty in walking. Difficulty in walking is involving between B12 deficiency. So whenever we will find a patient of anemia having difficulty in walking, we have to think of B12 deficiency. Bleeding tendency, easy bruising, prolonged bleeding after trivial injuries. Bleeding tendency, if we found in bleeding, easy bruising, we have to think that there are some clotting abnormality along with anemia, maybe leukemia, or maybe bone marrow infiltration disorders, even in aplastic anemia. Skeletal system, bone pain, arthritis, arthralgia, temperature, drug interaction, occupation, diet and social history. All of these points are very much important for evaluating a patient of anemia. Past history, it is very much important. Past history of any treatment, or he is taking any prolonged NSAIDs. Prolonged NSAID causes anemia, iron deficiency anemia. Family history, anemia, recurrent jaundice, uterine and childhood death. Family history is very much important for evaluating hemolytic anemia. So what are the examination point? After that, the examiner will ask you, you have taken the history, and what are the next examination you will perform? You have to think, look towards skin, color, texture, petechian ecchymosis, nail colonacia. It is very much important. In your long case, when examiner will, in your biopsy examiner will ask you that if you find a patient of colonacia, what are the differential diagnoses? So keeping in your mind anemia, you may have some other differential diagnosis. So on the basis of just colonacia, we can go through the evaluating a patient of anemia. So it is very much important, colonacia. In case of examination, mouth, mucous membrane pallor may be observed. Gums, bleeding or hypertrophy, tongue, redness, oropathy of papilla. Tongue is involved in iron deficiency anemia. So you have to examine it thoroughly. Abdomen, hepatomegaly and splenomegaly may be found in leukemia, lymphoma, or various chronic diseases. So you have to examine abdomen very meticulously. Central nervous system, cardiovascular system, we have to examine on the to look towards finding of any valvular heart disease or any history of any prosthesis. And central nervous system, subacute combined degeneration of spinal cord, that we have detailed earlier, that there may be finding of walking difficulty in case of subacute combined degeneration of spinal cord, along with other clinical finding. Superficial lymph node may be found in some chronic diseases like leukemia, lymphoma. bone tenderness may be positive in case of leukemia. Leg ulcer, rectal examination, hemorrhoid or carcinoma, it is very much important. A patient come to you with complaining of hemorrhoids or rectal bleeding. Later you will find anemic, so you have to evaluate the patient thoroughly. So all of the pointers are very much important for all of us, because these are really a clues. On the basis of this kind of finding, we have to go through the whole disease or whole system. Tourniquet test, no need to do this. So if you look toward this slide, very much important: microcytic, micro, normocytic and macrocytic. Look, on the basis of MCV, micro, normo or mega, there's no need to do just. Iron deficiency anemia, low reticulocyte count, high RDW due to chronic blood loss and diet deficiency. Thalassemia. A question is frequently asked to you: what is thalassemia and what is hemoglobinopathy? I think you should know the definition of thalassemia and hemoglobinopathy. Thalassemia, alpha, beta, major, minor. There are lots of types. Whenever globin chains are deficient, maybe alpha or beta, then it is thalassemia. And whenever there will be alteration of protein synthesis, alteration of amino acid sequence, then it is hemoglobinopathy. Sideroblastic anemia, anemia of chronic diseases. Look, chronic inflammatory disorder, rheumatoid arthritis, SLE. These two patients are frequently come to you with complaining of anemia. So we have to search all of these things. Macrocytic anemia, we have discussed it earlier. Causes of macrocytic anemia. Causes of macrocytic anemia is frequently asked in your final profession examination. Macrocytic occult blood loss, yes, we have to think one side, and if you know, we have to hemolysis in the other way. Comb test, no need to know this. To identify hemolytic anemia, we have to perform comb test. Combs negative hemolytic anemia, membrane defect, spherocytosis, elliptocytosis. We have to know some causes of spherocytosis and elliptocytosis if possible to know. Glucose 6% deficiency. A scenario may be given to you that a patient come to you with a history of fever, and he took some drugs. She is not able to mention the name of the drugs, and you find that after taking this kind of drugs, you find that he's anemic. What may be the causes? So we have to think in your mind that fever, that means she took some drugs, maybe a case of malaria, he took quinine, primaquine, chloroquine. So patient come to you with fever, he took some drugs, and later development of anemia. So examiner will ask you regarding this kind of clinical scenario. You have to answer. You have to think. You have to keep in your mind that there may be cause of glucose 6-phosphate reagent deficiency. So if there is glucose 6-phosphate reagent deficiency, RBC enzyme deficiency, so there will be development of RBC hemolysis and later development of anemia. Hemoglobin with hemoglobin S disease. No need to know this. Paroxysmal nocturnal hemoglobinuria, it is very much very frequently asked question. A patient examiner will give you the scenario. Patient come to you with general weakness with complaint of anemia, and he give you complaint that in his morning urine and there are color changes occur. Color changes of his urine in the morning changes occur. So what will be the cause? So we have to keep our mind that paroxysmal nocturnal hemoglobinuria. Simply just cause of it, paroxysmal nocturnal hemoglobinuria. Thrombotic thrombocytopenia purpura and DIC. It is very much important for knowing the cause of DIC. Pathophysiology, depletion of clotting factors. Thrombocytopenia, bleeding, renal dysfunction, hepatic dysfunction, respiratory dysfunction. Mainly the DIC causes overwhelming infection, malignancy, drugs, septicemia. Thrombotic thrombocytic purpura, the patient come to you with fever, renal involvement, neurological involvement, and thrombocytopenia, microangiopathic hemolytic anemia. These are the 1, 2, 3, 4, 5. These are the pentad of thrombotic thrombocytopenia purpura. In your examination, you may ask what are the pentad of TTP. You have to know this. Pentad of TTP. Normocytic anemia, hyperfolate, no need to know this. So I think, dear student, in your final professional examination, anemia is a very much frequently given topic, frequently easily asked topics. You will find it in your final professional in various topics, in various parts of your examination system, in your board examination, whenever you will evaluate data, in your long case, in your short case, and in your written examination. Various questions are given, and in case whenever you will explain data of anemia or iron deficiency anemia, we have to know the evaluating point of anemia. The examiner will judge you how you can evaluate a patient after finding a just koilonychia or leukocyte, or after finding a just lymph node. On the basis of just finding a lymph node, how can you evaluate a patient with anemia? Or just you find a patient with oral ulcer, how can you go evaluate a patient? So anemia is very much important topics. We should go through the all points regarding anemia. So whenever a question will ask you from any point, you will be able to answer, like what are the causes of iron deficiency anemia, what are the causes of macrocytic anemia, what are the causes of target cell, and what are the causes of anemia with lymph anemia, what are the causes of anemia with hepatosplenomegaly, what are the causes of anemia with leg ulcer, and what are the causes of anemia with walking difficulty. The examiner will ask on the basis of this kind of information, and after that you have to evaluate it, or you have to maintain an approach. You have to maintain an approach, maintaining the sequence of history taking, physical examination, investigation, and a bit of management. I think it will be very important for all of us if we, whenever we will face final professional examination. And till then, thank you.